Good morning, everyone, or good afternoon, or good evening, wherever you might be. So I thought I'd just build a little bit on what Melissa's been saying, and talk a little bit from the perspective of an institution like Chatham House, which of course deals with international affairs, global politics, policy, and I mean it's interesting because it a lot of this does really come down to framing and whose priorities and influence is being brought to bear on both global settings, but regional and national, and then subsequently subnational settings as well. And I think it's really important that we try and interrogate some of that. So, I mean, just more broadly speaking, what do we mean by health? And the WHO has a very good definition that it's not just the absence of disease, but a complete state of physical, mental, and social well-being. And this can be expanded out to One Health as well. And so when you're looking at the interface between humans, animals, and the environment, it's it's not just it's the health and well-being of the whole socio-ecological system that we're interested in. And so moving on to sort of what WHO considers the top 10 threats to global health. I think as soon as you see this list, you start seeing that politics does play a role in all of this. And if you unpick or interrogate some of these, you start thinking, how did this come about? How was A or B or C prioritized over D, E, and F? So what do we actually mean by Ebola and other high threat pathogens? What does high threat pathogen mean, for example? Threat to who? And how is that categorization made? When you say vaccine hesitancy, are we talking about middle class urban dwelling people in suburbia in a Western European capital who think that who wrongly think that MMR is associated with neurological conditions or just don't want to give vaccines to their kids? Or are we talking about a situation like you might have in northern Nigeria or in Pakistan where due to a whole host of reasons there's mistrust between the public and government, and so they're actually killing vaccine workers and healthcare workers. So whose interests are we looking at, and how is this being framed? It makes sense to have dengue there, but when you say antimicrobial resistance, for example, are we talking about actual resistance rates and deaths from resistant bacteria, or are we talking about equitable access to antibiotics in the first place, right? And are we talking about antibiotics, or are we talking more broadly about antimicrobials? And there is a difference here. So I thought I'd pick a couple of these examples, a couple of things from the list, and just talk a little bit about the politics of them and the policy, how that's developed. So starting off with the global influenza pandemic. So if you just go back the slide, it's fine. Starting with the global influenza pandemic and these high threat pathogens, I thought it'd be nice to talk a little bit about the avian flu as an example. Now, avian flu was first reported in humans in 1997. We then saw sort of very fast mutating, highly pathogenic strains of H5N1 being seen in and around Southeast Asia. So moved from Vietnam to Thailand to Indonesia to South Korea, Japan, and China. The first human case was in 2005. And the alarming thing was that it had a high mortality rate. So for instance, in Indonesia in 2007, it was up to 80%. But broadly, between the sort of 30 to 50% mark. And what the real fear was that, it doesn't transmit as easily from human to human. But if it combines with something like swine flu, which does transmit easily, you'll then have a flu variant with high mortality and high transmissibility. And that was the big fear. But the bit I want to talk about is around what happened in Indonesia in 2007. And what happened was that the Minister of Health, Minister Supari, refused to share samples with the WHO. And why was that? What had happened was that there's a global sample sharing network, and it's been in operation for about 50 years. But what was happening was that developing countries were sharing samples. These samples were then being sent out to specific labs in the US, the UK, Australia, and Japan, and they would then develop vaccines, share those developed vaccines with pharmaceutical companies in their own countries, and then sell it back to developing countries at really high prices, often unaffordable, and often without the knowledge or consent of the countries that shared the samples. And this is what Indonesia took umbrage to, that, we've shared these samples, you've given them out without consent and our knowledge, and then we're being expected to buy them back at really high, unaffordable prices. And so they've refused to share the samples. And what then ensued was a big hullabaloo at WHO and across the global health system. And it was only through really tough negotiation that what was then developed was the Pandemic Influenza Preparedness Framework, which now governs how samples are shared more equitably. There are principles within there that are withdrawn from the global legal system of the Convention on Biological Diversity, the Nagoya Protocol on sharing the commercial benefits of genetic materials equitably. And there's also been an element of technology transfer. And now you've got a number of countries in the developing world which can also manufacture influenza vaccine. But that was only through, really hard struggle and, the threat of not sharing samples at all, that a low income or middle income country was able to demand its rights and get that sort of technology transfer process and system set up. It's still far from ideal, mind you, because of everything that pharmaceutical manufacturers do within that framework is voluntary. So, sharing the technology, sharing doses, it's voluntary, and it's based on peer pressure, but it's a step in the right direction. And I think that's a real lesson for developing countries, that you need to stand up for your rights, because no one's going to give them to you. The other example I want to talk about was antimicrobial resistance, if I may, very briefly. And with antimicrobial resistance, this is a really interesting one, in that we were sitting in Chatham House in about 2013, and in the US, in Europe, there was this growing concern around rising rates of antibiotic resistance, and national governments were putting it on their national risk registers and seeing it as a real security threat, especially with rates of MRSA in hospitals, and things like resistant E. coli infections in hospitals as well. But the case needed to be made at a global level. So one thing was, of course, to develop an evidence base around it. The other thing was to make an economic argument around this and really build momentum around that, as had been done by the Stern Review on climate change. So there's certain tactics that people understand will gain traction with funders, with donors, and across the global system. So the science came through. There was a number of Lancet series commissioned around AMR and risk factors and how to control it. What are the most effective interventions, whether it's across human, animals, or the environment. And then around the economic, political side of it, the UK government commissioned the O'Neill report, which I'm sure many of you would have heard about. It was led by Jim O'Neill, who's a famous economist who came up with the term BRICS. And the interesting thing within that was that the RAND Corporation, which isn't exactly known for its public health credentials, ran much of the report and the gathering of the science and doing the analysis around it. And it came out with figures like, a lot of people would have heard about this in the media, and it's cited by lots of scientists all around the world that AMR could cause $100 trillion in damage to the global economy by 2050 and 10 million deaths. But where do those figures come from, and what do they actually mean? Firstly, I've never understood how they calculated $100 trillion, or how you calculate anything to come to $100 trillion. And that was based on every infection globally being entirely antibiotic or antimicrobial resistant. So that includes all HIV infections, all TB infections, all malaria infections, and all staph antibiotic or bacterial infections as well. And how likely is that as reality? And that's what the 10 million figure was also based on. So this would be if everything was globally was, every infection globally was resistant. This is the figure that you would come to, but that doesn't really come through, in the headline figures, and you just think that, oh, okay, we're going to have 10 million deaths if we don't do anything about this. So, but the framing of that was then obviously looking at these big killer infectious diseases, TB, HIV, malaria. But when it came to actually developing the subsequent programs, those were all antibiotic or bacterial infection focused. See, so when you were making the case for the argument, all the statistics we used were around antimicrobial resistance. But when it came to developing all the interventions at the global level and providing funding from donors, it all got distilled down to antibiotic resistance and tackling that. And so there was a disconnect there in terms of the science. What happened was that, we did like extensive reviews of the literature, and most of the effective interventions are actually developmental issues. So it's water and sanitation interventions, it's hygiene promotion, behavior change from that end of it. And this applies across the human spectrum as well as animal health. So, infection prevention control systems in animal settings or livestock settings is also really important, and those are the most effective interventions. But where did all the money go? The money all went into extensive surveillance systems, assessing and monitoring what labs are doing around the world, because of this securitized notion and this the securitization of health. So not only did it distort priority setting, it also distorted how the interventions were funded and then subsequently developed and delivered. And I think that's been, a lot of the issues around why a lot of the AMR interventions are so difficult to sustain, especially in low and middle income countries, because unless you look at, as Melissa was saying, the issues at that local level, which as far as AMR go, are fundamentally framed around access to effective antibiotics or antimicrobials, the quality of those, in many of these settings, they're substandard or they're counterfeit. In some tertiary care settings, neonatal settings in Nigeria, the resistant rates are up to 75%. In Southeast Asia, artemisinin in combined therapy for malaria, some of the resistance rates are 50%. These are huge numbers. We would
Osman. Sorry to interrupt, Osman, but we've got lots of questions coming in for. So if you could wrap up, and then we're going to start asking you questions.
Yeah, I'll wrap up. But I mean, what I'm trying to impress is that if it was being framed by local governments, subnational level authorities, community leaders, we'd be looking at very different investments in very different areas to tackle what are ultimately global problems. And it's short-sighted of those in power to frame it in this securitized way around their own interests, because in the long term, none of their programs are then sustainable. So, I mean, I'll just move on with my other slides, but there's not a whole lot to add with these other slides. A lot of what emergence and re-emergence of disease comes down to is a whole host of factors that influence it. What I would say is that whenever you look at an intervention or a policy or program, evaluate it using the sort of bread and butter criteria of public health practice, and that is evaluated around the 3 E's and the 3 A's: the effectiveness of the intervention or policy, the efficiency in terms of cost. Are you having cost savings? The equity of it. Are you, addressing the needs of the most vulnerable? Access to the intervention or the policy to those that most need it. The acceptability, cultural acceptability. Is that kind of an intervention or policy acceptable in that context or that setting? And then the appropriateness of it as well. It's not appropriate in a refugee setting, camp setting, for instance, to bring in place lots of dialysis machines where you need a whole lot of other infrastructure to run it. And then finally, the sustainability. And if you apply this to any policy, any intervention, you usually end up with the right answer. And it's when you fail to apply this kind of a framework that you get this distortion in priority setting and distortion in the types of interventions that are prioritized. And I just wanted to end with my last slide, which quotes a Scottish historian at the sort of beginning of the 19th century, so towards the end of the 19th century rather. And this is at a time when the colonial powers were convening these international sanitary conferences, which then eventually evolved into the creation of the World Health Organization. And I think, you know, unfortunately, many global programs are still driven by these unspoken intentions. And you know, it's funny, we've got a WHO collaborating center on mass gatherings, which has a big component on religious mass gatherings, and that used to be the real fear at the sort of the end of the 19th century, that there used to be these huge religious mass gatherings in places like India, and you know, colonial powers were they'd be terrified that that the people they have out there running these colonies would then subsequently be getting infected with things like yellow fever and other illnesses. Cholera, of course, there were many cholera outbreaks at the time. And it would be a shame that just because, you know, they were perhaps more vocal about it and more obvious about it because they were entrenched colonial powers, that these are the kinds of motivations that are still driving a lot of our global programs. So I think it's really important that low-income countries, middle-income countries develop strategies and methodologies to really have their own voice heard at the global level, and that might mean, you know, having stronger regional institutions or coming together so that you are able to address these issues and stand and speak up for your own rights, because sovereignty, national sovereignty, is a big issue, and just how much it's exercised is critical to speaking up for the little guy in all of this. So I'll just end with that, but